who are participating in the webcast, the slides are up on our website as well if anyone wanted to follow along. It's our deep pleasure this morning to introduce to you Dr. Raza, who is a professor of medicine and the director of the Myelodysplastic Syndrome Center at Columbia Presbyterian, or as she says, in upstate, 168th Street. We feel very fortunate to have Dr. Raza come. She has participated in the MDS study that's ongoing. I'd also like to, after I just do a quick reminder for everyone in the room what this study is about, I'll make a couple of other comments about her background, and then we'll move directly on to her presentation. For those of you who have seen this before, apologies. Those who haven't, it's a busy slide, but this is just to remind everyone that we have a two-part study that is ongoing. Only the first part, or part one, which is a phase 2 single-arm study, open-label study in MDS and lower-risk MDS, has been ongoing at the moment. And as we'll talk about at the end of this, we're actually in an expansion phase of that. Eventually, assuming those data turn out appropriately, the study is designed to go to a phase 3 randomized double-blind placebo-controlled study, but we have not yet started that. So everything that Dr. Raza will be talking about in terms of MDS data regarding imetelstat is actually from part one and from the initial set of 32 patients. This is a brief background on Dr. Raza. She has had a distinguished career in medicine, and as you can see, trained both at Georgetown, University of Maryland, and did a fellowship in medical oncology at Roswell Park. And Dr. Raza is one of those triple threats. Not only does she teach, I think she's giving grand rounds tomorrow at Columbia, she also has a very active lab, as well as sees, I'm told, 40 to 50 patients a week with MDS. So she's really the right person to be talking to us today, I think. So I think that without any further ado, I would let Dr. Raza take over, please.
Good morning, everyone. Welcome to New York if you're from out of town, like some of our colleagues here. Thank you to Anna, Olivia, and John for giving me this opportunity to not only tell you something about the iMerge trial, but also to introduce the subject of myelodysplastic syndromes and lay the background in which I would like for you to look at the efficacy of clinical trials and of this drug in particular. So I was telling Anna last night that, in fact, this is a slide which I show every new patient who comes to my clinic with a diagnosis of MDS. Why? Because knowledge is power. Once they start to understand what is it we are trying to do, it makes so much more sense for them, and they really own their disease and their treatment. So the idea is, of course, that we find abnormality in the blood, and we always want to look at the bone marrow after excluding the obvious causes for having low or abnormal blood counts. And when we take a piece of the bone marrow and put it under the microscope, we first see the background cells, or the microenvironment of the bone marrow, and on top are the hematopoietic stem cells, which are actually the ones that make blood by first making copies of themselves, and then in a healthy adult, in addition to dividing, they mature into white cells, red cells, platelets, and enter blood. And can you imagine that this traffic involves 1 trillion cells almost every 24 hours? So it is an exceedingly dynamic system. Lots and lots of cells are dividing, they are copying DNA, and they can make mistakes. So hundreds, if not thousands, of cells with mutations are produced every day, but they get efficiently removed by our immune system. MDS is a disease which is particularly associated with aging. sequencing of human genome project leading to the Human Genome Atlas has shown that 1 to 2% healthy adults can be walking around with mutations which are associated with MDS, but they don't have the clinical disease. Why? Because they may have a mutated clone of cells, but the clinical syndrome will only develop when this is combined with a microenvironment that's also suitable to produce the disease. In other words, aging causes certain pro-inflammatory changes in the bone marrow microenvironment, as well as the immune system becoming a little decrepit. As a result of which, what happens is that we have the microenvironment cells, we have the stem cells. One of these which is mutated just by random chance. It has really nothing to do with the lifestyle that the patient led or how much he smoked or drank or exercised. It's a random thing, but the problem is in the immune system, which missed killing this cell, as a result of which, by the time normal cells divide into 2 or 4, this one divides into hundreds. And this is the first thing I did as a fellow, was to do detailed cell cycle kinetics in vivo in patients by giving them infusions of thymidine analogs, IUDR, BRDU, and showed that this, by the time MDS is diagnosed, basically every cell in the bone marrow is part of the clone. So we call this monoclonal, which means now here they were multiple colors because cells were coming from multiple stem cells. Here they're all coming from one, so this is monoclonal. The beauty is they're still able to mature, but they look abnormal, and that's what we call dysplastic. But they become fully mature white cells, red cells, and platelets, and this is where the second problem happens, that many of them will drop dead by apoptosis prematurely. So now the number of cells entering blood is reduced, and that accounts for the cytopenias that we are trying to treat. And the reason to lay down this slide for you is that with most of the drugs we use, in fact, all of the drugs that exist right now in MDS, we are not touching the clone of this MDS clone, because if we did and if we shrank, we would cure the disease with existing drugs. We don't. Whether it's lenalidomide in deletion 5q patients or it's hypomethylating agents, they work for a certain limited period of time, even if they work. Why? Because very little is being affected right here. Now, what we are trying to do is protect this part from dying. Either it's from pro-inflammatory cytokines which are there, TNF-alpha, TGF-beta, that are killing off these cells. Whatever we are doing is trying to protect the maturing cells from dying, and they are able to mature, so that's why the counts can improve. Another thing that can happen to these patients is that one of the daughter cells belonging to the myeloid lineage does not mature, and an immature myeloid cell is a blast. Up to 5% blasts are normal, but if it reaches 20%, that is acute myeloid leukemia. Now, when a patient walks into the office, we want to know how long is the survival going to be for this patient. Why? Because MDS is a heterogeneous disease. And this prognostic classification has been provided by the IPSS system, which assigns a score depending upon one of these 3 parameters. What is the percentage of blasts? What is the cytogenetic abnormality? And how many blood counts are low? The problem is that this accurately predicts prognosis in 39% of the patients, because this is a prognostic nightmare. All you can say is that if I saw 100 patients with exactly the same parameters that I'm seeing now, 50% would behave like this, 50% like this. You cannot apply a curve like that to an individual sitting across the desk from you. And this is one of the problems also, because the variables we used to determine the classification are quite gross in terms of having just how many blood counts are low. So recognizing some of these pitfalls, a revised system was introduced in 2012. But again, it takes into account the same 3 parameters, except it just doesn't say how many blood counts are low, but also looks at the profundity of cytopenia. and then assigns a score. But I don't have great hope it's going to be